Good afternoon, everyone. Welcome to Medical Grand Rounds. Before we begin, I would like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst its Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Our speaker today wears many hats, but she's being introduced by the head of clinical epi, Dr. Robin Tamlin. Are you there to introduce our speaker today?
Yes, I absolutely am. Okay, it's a super pleasure to introduce Dr. Nancy Mayo. A little fun fact, Nancy and I started at McGill around the same time and actually cohabited office space together and got to know each other pretty well. So she's just an amazing scientist. She's a Distinguished James McGill Professor in both the Department of Medicine, Division of Geriatrics, and Division of Clinical Epidemiology, as well as the Department of Physiotherapy, Occupational Therapy. Her research focuses on function, disability, and quality of life, the design and analysis of complex interventions, and the analysis of rich data from many sources. She's an amazing and enthusiastic scientist, and people have loved both teaching with her and working with her. So I'm sure you'll enjoy her presentation. Nancy, over to you.
Thank you. I want to introduce you to the study we've done on COVID, on the post-COVID syndrome, with my colleagues who many of you will probably know. Mary-Josée Brouillette is from the Department of Psychiatry, and Leslie Fellows is our current dean. And Leslie and Mary-Josée and I have a long history of working together in all sorts of diseases I know nothing about, but I get to learn about these things. And we had a great research team helping us with the analyses and data collection. So I wanted to make the talk somewhat slightly modern and interesting. So it's essentially, what do persons and machines tell us about the life impact of long COVID? So the learning objectives are to demonstrate the effects of the post-COVID syndrome from the person's perspective. And the second one was to demonstrate statistical and machine learning methods that can be used to quantify and visualize what patients are telling us. So I have a bit of a conflict of interest in that one of the tools we used in this study is a product of my company, Physiobiometrics Inc. It's a McGill spinoff in the digital health space, and I'm the CEO of that. And it extracts data that is routinely collected from your cell phone for purposes of research. It's called StepCatcher. Page down. So the long COVID syndrome. When we started this project, and I'll give you a timeline in a few minutes. When we started this project, this is what was known. The long-term effects of COVID-19 was associated with 200 symptoms. So this is not helpful. We got 200 things. Every single study that was reviewed here had a different study design with varying degrees of bias. There were different denominators in all of these studies, different numerators. All of it was from the medical perspective. And it was the era of the pre-Omicron variant, which was the more severe variant. So you can see this huge list of things that were going wrong. Now, in all fairness, this condition is not easy to study. It's not a diagnosis. There is no diagnostic process. Self-reported symptoms, sometimes they're 4 weeks, sometimes they're 12 weeks. And the rates of symptoms range from less than 0.5% to 95%. So we have a very wide range. Stats Canada estimated 14% of those infected with the COVID-19 virus developed the post-COVID syndrome. And we talked about different denominators or different sampling frames where they got people from, and different response rates for study samples range from 100% to 10%. So the global aim of our study in long COVID was to create a functional profile of people who self-identify with the COVID-19 syndrome. And it was to guide self-management because there was no medical management that had any particular evidence, and to prioritize people for more in-depth assessment. This was launched a bit with Emily Falcone from ERCM, who was developing a biobank for people with long COVID, but had no way of prioritizing who she's going to assess. And then apparently 1,500 people signed up. So we said, maybe we could help you with that. So specifically, the objective was to estimate the extent of the symptom, functional, and quality of life burden among people identifying with post-COVID syndrome. So this was our design, and I certainly didn't want to do a boring epidemiological bullet list, so I'm giving you cheerful balloons. So it was self-reported 4 weeks plus. It was a longitudinal study. People were queried every 3 months for 18 months. The data is made open source. We did social media advertising. We did some recruitment from the St. Mary's Hospital Primary Medicine Clinic, the ERCM, as I said before, and we did some specialized targeted outreach. We did online recruitment through a website, and we were aiming to recruit a sample of people likely to need or desire health services. So this recruitment strategy got at the people who were looking for services, therefore they were looking to enter our study. So you just have to be a little bit careful that you can't interpret these results of prevalence because the denominator is not known. The sample self-identified, and it was recruited, as I said, from social media. It also attracts people most likely to want care, which was useful for us in terms of trying to plan services. So there's shifting sands. So the minute we launched our study, the World Health Organization came out that the clinical management of COVID-19 should avoid talking about physical exercise as part of the recovery. Anybody who has followed any of that knows that it's not strongly based on evidence. It was based on trying to provide some calming message because there was some collaboration with people that had chronic fatigue syndrome, and this concept of post-exertional malaise was very important at the time. So we had to post that exercise is not recommended for people having post-exertional malaise or have been diagnosed with chronic fatigue syndrome. So we had to kind of alter our message, and this was some of the evidence that was posted. So here was our measurement wish list. So we did not want a symptom checklist for people to check off symptoms. They'll check off everything. There's actually a literature on that. At the time, the only measure that was recommended for the post-COVID syndrome was the SF-36, which is most widely used health status measure in the universe. Fatigue was key, particularly post-exertional malaise, so that had to be a big focus. We wanted to have brain fog, but we wanted both self-report and testing of cognitive status. We wanted to test taste and smell. There was nothing known about the mental health profile of people with long COVID, so we could not choose any particular measure. And we wanted smartphone capture of physical activity. I didn't want self-report physical activity, so we were able to get step count. We did cohort study best practices. I've done a lot of observational research in my time. I don't want to do that anymore. We provided guidance for people with various issues. We provided activity tracker. We provided people with a personal health dashboard. We gave them the results, and we provided them with self-management resources. On our website, we had self-management resources for shortness of breath, emotional distress, sleep, fatigue, loneliness, walking, memory, alcohol or cannabis, and tobacco. This was an early infogram that we sent out at regular intervals. This was done at 300 people. And we just gave them a little bit of information about essentially you are not alone. There's a whole bunch of people that are in the same boat. And this is a little picture of their dashboard showing what's going well and what is not. And anything that was yellow or red, they're directed to self-management resources. So our measurement plan was to follow a standard outcome measurement plan, the Wilson-Cleary model, very well known. It's a bit of it's a medical model, published in JAMA in 1995. And essentially, under this model, you think of your outcomes in terms of biology, symptoms, function, health perception, and quality of life. So we lined up all our measures under these rubrics. We had pre-morbid, pre-COVID morbidity, sort of. It wasn't very well answered by people. We had symptoms related to visual analog health states of classic things, anxiety, depression, sleep, SF-36 vitality, SF-36 mental health index. We had post-exertional malaise. We had a question on PTSD, and we had questionnaire on shortness of breath. So for function, we had, again, the SF-36 physical function. We had daily step count. We had self-reported cognition, roles and responsibilities, daily activities, health perception. We had standard, how do you rate your health? Also the best question to ever ask in the universe, how do you rate your health? Excellent, very good, good, fair, poor, predicts everything. And another SF-36. And quality of life, we had the visual analog scale, the EQ5D, which is a utility measure, and the PGI, which is a personalized measure, which will show you a lot of that. So here was the cohort. They were on average 49 years of age. We had people between 18 and 83. The time since the last COVID episode was 129 days to 400 days. And that's because we didn't, I don't know what happened to my timeline slide. It kind of got eaten up, I think. Is that it took a year before people were really understanding that there was this big, huge thing called post-COVID syndrome. McGill closed on March 2020, and we were alerted through Emily Falcone's clinic by April 2021 that she had 1,500 people with long COVID wanting, biobank testing, and, she needed help with quantifying them. So it was about a year. So the sex distribution was more female, and that's sort of known that the women seem to report more than either have it or report more or enter studies more. Education, we usually always get a highly educated group. We did a lot of outreach to try and get people from different areas. We have largely white. Language we're in Quebec, so it was more French. And 96% of people were vaccinated one or more times. So this is what the cohort looked like over time. Not surprising. So recruited 545 people to begin with. And by the second time, we had lost people, and we really were only trying to get out to maybe 5 or 6 assessments, and the cohort diminishes. This is expected. So how did we start finding out what people wanted? So I didn't want a checklist. So what we used, it's called an individualized measure to identify outcomes that matter to people with long COVID. This is the patient-generated index. What it does is it says, name 5 areas, most important areas where your health has affected your life. It's free text. You'll see the joy of that later. Free text. They rate how good or bad it is, and 10 is great, and 0 is terrible. And then they spend points. If you could fix any of these areas, where would you spend your points? So that is like a priority rating. That is a weighting. So those of you who know anything about utility measures, is that it weights these things. And that's the joy of this measure. So we had 2,463 text threads about what is bothering people with long COVID. And we classified them based on systems, because at the time we were trying to say, if we were going to make a clinic, who's going to populate this clinic? People were not jumping up to do this. So general systemic is essentially fatigue. Cognition was the next most common area nominated. Pain, respiratory problems, cardiovascular, neurological, ENT, GI, mental health, sleep, eye, blah, blah, blah. So you can see that it's really being predominated by things that are very difficult to manage. Fatigue and cognition. So based on the priority, we then ask people, well, what are your priorities for improvement? And they get 10 points to spend. So if they spent 6 points on any area, it was a priority. Fatigue was the #1 priority area for improvement, followed by cognitive problems, respiratory, and taste and smell, which I thought was quite interesting. And then the rest of the things were less priority for fixing, but that those 5 were of very high importance for this group of people. Just to give you a little snapshot of function, this is the SF-36. In blue are the Canadian norms, which we have, thanks to the osteoporosis study. That's where the norms came from. And in blue are the Canadian norms for people between the age of 45 and 54. And in yellow are the population with long COVID. So you can see that their life has shrunken to the size of a peanut from a life that has capacity, very strong effect. So given that fatigue was the main problem that people were reporting, we looked very carefully at fatigue. So just to remind you what fatigue is it's a clinically relevant symptom. And it's characterized, it's characterized by difficulty in initiation or sustaining voluntary activities. And it is distinguished from the lay notion of tiredness. We are all tired, but we are not necessarily fatigued. There is no agreed upon measure for fatigue, and the components of any symptom are intensity, frequency, duration, impact, and bother. You either measure them all or you measure them one at a time. You don't mix them up in a big soup and try and have a measure that is made of this fruit salad. So you pick one to target. So we targeted fatigue severity, and we picked items from the SF-36, from the PEM, the 1 VAS, how do you rate your fatigue? A couple of items, some shortness of breath, because lay people don't distinguish between being short of breath and being tired or being fatigued. We had a question on need for rest, and we had time spent in moderate activities. We ran that through what's called a RASH analysis, which is essentially a logit transformation of the proportion endorsing the items, and it produces a fatigue ladder. It produces a measure with linearized units that can be used legitimately in mathematical transformations. This is what it looks like. Energy, obviously you have lots of energy. You're at the high end of energy, and it's coded to have fatigue as high. So these are just some of the items that we used. Okay, so what does fatigue look like? So we use something that's called group-based trajectory modeling. It's a methodology that groups like with like. What your eye sees in terms of a trajectory, it'll group it together. It's a probabilistic model. It is not a deterministic model. People are not there. They're probably there. So this is the cohort, but this is the average fatigue according to the number of visits. And I put that up there is because fatigue didn't depend on whether you dropped out or not. They had the 60 out of 100, which 100 is like the worst fatigue possible. 60 was the average, and it was the people who only came once, the people who came twice, the people who came 3 times, 4 times, 5 times, 6 times. We could not see any evidence that attrition was based on the highest dropping out or the lowest dropping out. So they started around 60, and this is what it looked like over time. The 2 highest groups, which are group 6 and group 5, who started way up, did not change over time. There was a tiny group of people in the high end, but not the highest, who improved. That was only 4% of the population. We'd like to look at those magic people and see what happened there. Moderate fatigue improved over time, and people with low fatigue did not develop fatigue. So high fatigue does not seem to improve over time. So let's look at cognition, often called brain fog. We had a self-report questionnaire, and these are the proportion of people reporting they have cognitive symptoms almost every day, and it's in around 60%. Report cognitive symptoms every single day. That's pretty scary. Leading are things like losing concentration, can't multitask, can't remember what they were about to do. You can imagine trying to hold a job down with this kind of burden. We also had a cognitive test that was done on the computer. It's called the symbol digit modality test. It's kind of like testing your hieroglyphics. And we had the Ravens matrix. Ravens is a kind of an IQ test. So you probably all know about cognitive testing, but the thing is that not everybody has the most intellectual capacity. So unless you kind of sort it out by general IQ. So in this model, what we see here is that you see over here on the blue, this is on standard deviation units. So this is almost a half a standard deviation, which in the absence of anything else is clinically relevant. This group did very well on the symbol digit modality, but they weren't actually the most intellectually apt people. So we're not worried about them, they're doing well. This group did very well, but they're smart. So that's expected. This group did very badly, but they are not the most intellectually able. It's this group. They did poor on the symbol digit modality, but their expectation is that they should have done well. This is the discordant between the sort of IQ and the performance. And this was a big cluster. This was the biggest cluster. This was 161 people had a cognitive test burden. What happened over time? Nothing. 5% improved, 20% declined in cognition over time. Same model, group-based trajectory analysis. What happened to the symbol digit modality, which is that test of cognitive performance? No change over time. A little snapshot of the symptoms. Shortness, anything in green that isn't green is high is worse. So shortness of breath, 40%. Their mean score was 4 out of 10 or 40 out of 100. Those of you who know that visual analog scale, 0 to 10, where 4 is usually the cutoff, it's the same thing. So in the clinically relevant range for shortness of breath, distress, and sleep and fatigue was close to 7 out of 10 or 70 out of 100. And if you look at cognition, they were the opposite, and very low cognition and very low physical function for that age group. So I showed you a bunch of symptoms. How do they cluster? Clusters a bit of a machine learning type of analysis. So we identified 5 clusters. And the first cluster at the bottom is people that have high on everything. They're bad on everything, and high is worse. And you can see that's a big chunk of people. 132 of our sample were high burden. But the next thing is fatigue. It is like pairs. Fatigue and shortness of breath, fatigue and sleep, fatigue and cognition. And then we have a bit of a low burden. So it seems that fatigue is everywhere, but it seems to pair up with almost every other kind of symptom, making it kind of an interesting group of paired people. So what is the effect of these symptom clusters? So we looked at it on self-rated health, health utility, and quality of life. So you can see the green, which is low burden, has, pretty good rating of health, although not amazing. Normally at this age, people would rate their health close to 90. They're rating their health only about 65. And then you see the paired clusters are about the same. The fatigue plus, about the same. And then the high burden, very low quality, rating their health. Health utility, this is from the EQ5D. On average, it's about 0.6. It's equivalent to stroke, multiple sclerosis, COPD, and severe diabetes. So again, you see that the low and the high burden, and then the middle burden doesn't distinguish. And this was quality of life. So these clusters had impact on the people's lives. Okay, we looked at the smell test. The smell test was actually something you do at home. It's a colleague of Leslie's. And she developed this test, and you actually smell peanut butter, and there's a rating scale, and you smell vinegar. So what I learned is peanut butter is olfactory and vinegar is trigeminal. So you can see that the low burden they had 20% still couldn't smell peanut butter. And then when you got to the high burden, So the smell and the seemed to be completely independent. And this was work. This is symptom cluster on work. It's done with an odds ratio. If you have that high burden, you're 27, almost 27 times more likely to be stopping work because of illness. I promised you mental health, and I said we had no idea how to measure mental health. So we used my favorite measure, which is name 5 symptoms of your mental health symptoms has affected your life. This is a little word cloud that the words that people said, anxiety and depression. And then we ran that through a large language model called topic analysis. It's bidirectional encoder representation with transformers. It's a type of natural language processing that groups unstructured text into topics. So instead of having a word, you have a topic. And it aims to discover the most relevant topics revolving around a specific term for some more in-depth understanding. So this is what it produces. Very pretty. So what we've circled are the 5 ways in which anxiety is represented in the text. So I showed you a word cloud with one word called anxiety. In the topic analysis, we have a generalized anxiety, a fear, worry anxiety, a stress, post-traumatic anxiety, panic attack anxiety, and an anxious, nervous, obsessive anxiety. It's the same thing for depression. It was manifested 5 different ways. This is a depression unsatisfied with my life, a discouragement depression, a hopelessness feeling, and an emotional distress depression, a sadness, a depressed loneliness. 5 different ways that depression was manifested. Just summarizing it, these were the prevalences. Generalized and social anxiety. Anxiety was the biggest burden with different topics. And you can also see there was a cognitive topic in 22%, irritability topics, and mood swings, and a lack of motivation topic. So that was the richness of mining that data. We also looked at physical activity and steps per day just to anchor it. 1,000 steps a day is people who are disabled. They probably either in a wheelchair or they walk with a walker. 3,000 steps is considered very low active for an adult. And this was our walking. We had 11,000 person days of walking. We used the threshold 3, 5, 7, 9. 3 is low active. 5 is, well, 3 is sedentary. 5 is low active. 7 is active, and 9 is highly active. So you can see that everybody is in the sedentary capacity. We had 22% of days with 0 recorded meters. The instruction was, because it's on the cell phone, is to take the cell phone when you leave the house. Our interpretation is people did not leave the house with this. This was as minutes with cadence greater than 30 steps a minute. So 30 steps a minute is called incidental walking, you know, from your stove to the fridge. And you can see there's a lot of very low caliber steps that are not going to really change very much in your health. This is being analyzed now with a deep learning model, which is a bit of a challenge, but stay tuned. So now we're doing something a little bit more collective. So one of the things that I worked on with Leslie and Mary Jose, and we started this in looking at HIV, is everybody talks about brain health. So what is brain health? Is brain health a unified or a dispersed construct? Our hypothesis is that you don't have your depression and your cognition, and it's all lined up in nice little silos, so you can call the cognitive doctor or the anxiety doctor. It's a bit of a smush. Now, in HIV, we found that it was a unified construct. Papers out. This is long COVID. We asked the same question in long COVID. Is the brain being uniformly affected somehow by this virus? And this is a network analysis. This is definitely a machine learning approach. And the answer is no. The answer is there are pockets of things. There's cognition, which is separate from this sort of more social emotional, which is more the depression, which is more the behavioral here. In the behavioral, it's more the anxiety and irritability. But interestingly, way over there on the right-hand side is smell, is smell. So on the S4 is the olfactory, and on the bottom it's the trigeminal. And I told you they connected to nothing. You can see they connect to nothing. There seemed to be a different package in that long COVID. So it's a dispersed network. So putting this all together, we ran a structural equation model. So for those who know about structural equation modeling, it fits a model to the data. You have a model and you fit it to the data. So we've had the Wilson-Cleary model. So I'm looking at this Wilson-Cleary model, and under symptoms, you're going to put pain and fatigue and shortness of breath and anxiety and depression. But one of my jobs in managing this project is I got to talk to the people who were answering our questionnaires. And they were all saying, why are you asking me about depression and anxiety? If I could work, I wouldn't be depressed. You know, if I wasn't so tired, I wouldn't be so depressed. And I'm sitting there going, well, that's not our model. Our model is the symptoms affect the function. So we didn't like that model. So we found in the literature an article that did a thematic analysis. They only had 47 people, but everything that they identified from what the people said, they have a reference. You can't see it, but there's a reference there. So they matched it up with the literature. So they said, people say this, what is the literature? So they came up with what they call symptoms and impacts. And the symptoms are the fatigue and the cognition. There's other things, GI and shortness of breath. But the impacts are on mental health. And that's what our people were telling us, that mental health is not primary. It isn't the virus that gives you depression. It's the fact that I can't work and I can't think that is giving me the depression. So we modeled that model. And this is what we found, is that fatigue, nothing else fit, the shortness of breath and pain that didn't come out. Fatigue went directly to participation, which was, we broadened it, we made it physical function, sick leave, role interference, usual activities. Fatigue went to cognition. If you're tired, you're not functioning as well. We all know that. Fatigue went to mental health. Self-reported cognition went to mental health. Tested cognition never goes anywhere, ever. It seems to be measuring something else. It goes a little tiny bit to participation. So we did not have a link between participation and mental health. We found that interesting. That's, people said, I can't work and therefore I'm depressed, but we didn't find a statistical link. It doesn't mean it's there. It just, we did not find it using this model. So it seems that these two very important symptoms of fatigue and cognition are very important for driving the life impact of long COVID. So our lessons learned, it's a complex problem. It needs a complex solution. People report a high burden of symptoms. The symptoms cluster. Fatigue predominates. High fatigue persists over time. Suggestions from mechanisms are welcome from the audience. Fatigue is part of every cluster. Evidence that fatigue drives cognitive challenges, which drive participation in mental health. So it's that fatigue, cognition, mental health. Mental health seems to fit best as an impact and not a primary target of COVID-19. And COVID-19 infection seems to have specific and not global effects on brain functions. So if we go back to the beginning, I hope I demonstrated the effects of the post-COVID syndrome from the person's perspective. And I hope I showed you some nice kinds of models of visualizing these effects. We have some publications. We've published that topic analysis of mental health. We've published our measure of fatigue. I have a pharmacy person doing pharmacoepi with us, and he looked at the medication utilization patterns of people with post-COVID. And according to Mary Jose and Leslie, there's a really interesting cocktail going on there. Not sure their efficacy, but I'm not a drug person, so I won't talk about that. And then we have published, attempted to publish. We are now in 14 months of review of our first paper. Fortunately, we stuck it in medRxiv. So it is available on medRxiv, and that is essentially the summary of this talk. Hold all the nice machine learning things. Long COVID is really awful. And our conclusion when I've done it for other groups is that most of the symptoms are under the scope of practice of people in the rehabilitation professions. Physical and occupational therapy, social work, psychology. Most of those symptoms are managed in those professions. And doesn't seem to be that a lot of medical management is going to help a lot. Fatigue is difficult to deal with. Cognition is difficult to deal with. Certainly any of the respiratory and the cardiac problems, absolutely. That's fine. They're proportionally minor. So that is it. Long COVID is not a good thing to have. May you never have it. And we have lots of time for questions.
Thank you very much, Nancy, Dr. Mayo, for this fantastic presentation. A really, great showcase of the epidemiological work that you did there to advance this. Thank you so much. So it's both sort of content and both, I guess, the research.
But I may not have the answers.
That's right.
Well,
Are there?
You guys can answer them.
We'll take questions. Mark, Dr. Roger here, if you have a question.
Yeah, I wonder, Nancy, you could speak about sort of how we go from here to diagnostic criteria. And I recognize these are self-identified, self-report, self-volunteer, and not sort of population-based. But yeah, any thoughts about diagnostic criteria?
Well, I'm not a diagnostician. That's not my job. But it would seem to be extraordinarily difficult. I mean, how are you going to measure fatigue? You got a biomarker for fatigue? You got a biomarker for cognition? I work in the digital health space. We're looking at digital biomarkers. I actually think probably gait trace would be it. Your gait was the ECG of your walking. I think it's difficult. You have to rely on what the patients say. Believe them. And I hear this all the time. The doctors don't believe me. They don't believe I have this. Believe them. They have it. I listen to these people. It's horrible. So, I think you have to believe it. And then you have to say, okay, maybe I don't need a diagnosis. Maybe I just need to treat the symptoms and find out if there's something terrible, like some cardiac, or a lot of people, the drugs, a lot of puffers being given, which would make sense maybe for shortness of breath. I'm not sure it's going to come into a diagnosis. You're not going to take an image of their brain or.
Okay, Dr. Dasgupta.
Okay, in the next step.
A hard study. That's what I'm saying. There's the content, and then there's actually executing this.
Thank you,
study.
Leslie and Mary Jose.
And what's really interesting is it's not like you have a classic comparator. It's kind of taking this mass and making kind of sense out of it. And one of the things that strikes me as I'm listening is.
No, one of the things that's striking me is that the symptoms resemble like what everybody feels like when they have the flu or COVID acutely, but they kind of go on over time. And I'm wondering if you thought about parallels with Lyme disease and sort of other viral conditions
right.
and what happens after.
Thank you.
Well, I don't know that much about Lyme disease, but what comes up really is chronic fatigue syndrome, which is that myalgic encephalitis. And of course, that community has embraced the long COVID community, and they are drawing their own parallels. I think that long COVID affects 14 million people, and chronic fatigue syndrome affects, a handful. So, I don't know, the tail is wagging the dog. I think we have so much information on long COVID that we could apply to other, fatigue defining illnesses, which is what they're called. And that would include multiple sclerosis. There are fatigue defining illnesses, but I don't know that much about Lyme disease. I don't associate it as a fatigue defining illness. And I don't know much about the cognitive burden. It may be more short-term. This is long-term cognition and affecting not only self-report, but testing cognition. So I think it's something going on there.
Dr. Arietta, would you like to unmute for your comment?
So I mean, I was kind of throwing this into the soup just to provoke a discussion on nature, since we're seeing that exposure to green spaces improves many situations. I was wondering if that, I don't think that was looked at specifically in your cohort in terms of steps and so on, whether that was steps outside or steps inside or what it was exactly. And I was wondering what your thoughts were on that.
Absolutely. You know, exercise, physical activity, outdoors is very beneficial for a huge number of reasons. This group was not going anywhere. We had a daily questionnaire that at 5 o'clock every day, you get a message, fill in 5 symptoms and tell me what you were doing during the day. They are doing cooking, driving, going on a bus, trying to work. There was nothing about anybody going outside for a walk or doing anything. They were doing the very bare minimum to get through their day. Now, you recognize that these are the people that are in the most distress. The other thing is that the World Health Organization really scared everybody, and the long COVID people said, I have long COVID, I have to stay in bed. And whether that is a disservice or not, time will tell.
Thank you. Dr. Rosenblatt, do you want to unmute?
Thank you very much. You've answered some of that excellent and very interesting and important talk. I'm always looking at what is the appropriate control group when we're looking at things like this, whether it is in fact the chronic Lyme disease, not the acute Lyme disease, because we see a lot of this, and the chronic fatigue syndrome. And also all these, I know you say listen to the patients, but if you go online, there are an awful lot of, shall we say, non-traditional medical treatment being offered to an awful lot of these people. The other comment I made, one of the things you can measure easily is smell. And so that is the group I would focus on, because at least there's a constant that's got, if not a biomarker, something that is tangible. So and you say those don't differ at all from the others, right?
They didn't differ much by the clustering in the other syndrome. They didn't cluster. So, you know, this is not my area. So, you know, clearly there's something going on with taste and smell that is different from the other kinds of symptoms. But I think I was going to say something about your first part of the question.
The appropriate control group.
Yeah. So this is it's not a control group in this sense. Where we get the controls from is what Health Canada tells us about the Canadian population pre-COVID. So,
but you know what their situation, even their own subjects, what were they like?
Yeah, I'm just assuming that these people who got COVID, and I think there's not probably one person in this room that didn't have COVID. I think we arose from the general population. It was indiscriminate. COVID was indiscriminate. Everybody got it. So in our paper, we compare it to the Canadian norms. So for example, recruiting from the hospitalized population, 6% of the Canadian population was hospitalized. 5.8% of our population was hospitalized. So recruiting from a hospitalized cohort is ridiculous. You got some special kinds of people. So I think the control is going pre-COVID. We have Stats Canada data to say, how did people rate their health before COVID? What was their physical function before COVID? And assume they arose from the general population. I mean, it might be, you know, when I look at the EQ5D, I say that utility rating looks like stroke. It looks like diabetes. It looks like multiple sclerosis. It looks like Parkinson's. These are serious conditions that nobody would say this is not serious, and they have the same utility score.
Thank you. Michael McLibben, do you want to unmute?
Sure. You know, I mean, it's another variant of just the same question, which is I mean, chronic fatigue. Those of us in infectious disease have recognized chronic fatigue as coming post many kinds of infections, right? It's been going on even as you know, kids knew generations ago that you got mononucleosis and some proportion of them landed up with chronic fatigue and missing a semester and this and that. And it's gone on with, I mean, you know, COVID and Lyme are the most recent ones, but it's been a thing going on forever. And I guess what it comes down to is my question is there any distinctiveness about the post-COVID syndrome. I don't know that anybody's done the kind of work that you've done now with some other variants of chronic fatigue over time. But maybe there is. Is there something that makes this entity distinguishable in some way from any of the other chronic fatigue type of syndromes, whether they be post-infectious or not?
Right.
Can they be distinguished based on the kind of analysis that you've been doing? Does
Right.
it come? Yeah.
Yeah, so I guess the closest, and again, I thank Mary Jose and Leslie for roping me into studying HIV. And we took exactly the same model. We applied all of these same things. Interestingly, HIV has a unified brain health concept. We had a very small world network analysis, meaning every single symptom is connected to the next symptom by 3 jumps, whereas we did not have that in long COVID. So that's the only kind of infectious disease anchor that I have. I understand the mechanism is a bit different when the retrovirus can affect everything in the brain. So they also have very little change, and that's a study we just finished over 10 years, very little change in symptoms over time. But the problem with, of course, HIV, we're dealing with a survivor population. The older population survived that pre-heart era. So I don't know, I'm not infectious disease. I'm sure there's lots of experts that might say, does Lyme disease look like this? I don't know. Does chronic fatigue syndrome does not seem to abate. It does not seem to improve. I don't know that it's been studied this intensely. I think it's a lot of more anecdotal, but I leave it to the experts.
Thank you. Natalie, Diane, would you like to unmute?
Sure, thank you very much. So my question really just relates to how does the syndrome evolve over time? You know, the virus mutated over time, and of course the vaccine was introduced. I'm sorry if I missed the years of collection, but any idea of whether this changed over time?
So it was, you know, again, I don't know what happened to my timeline slide, but it wasn't until April 2021 that people noticed that there was this chronic, long COVID. And that's when we got on board with Emily Falcone. And then it took us a year to develop that protocol. We didn't know anything. We had no idea. So we had to go and look at the literature. We had to write a protocol. We had to get it through ethics. And then the World Health Organization crashed down and we had to go change everything. We didn't recruit till September 2022. And then we finished recruitment. We had 18 months. We finished it in March 2024. What I hear from my timing experts is it was pre-Omicron. And pre-Omicron was the worst virus. We had 6 months to recruit our sample. We recruited them between September 2022 and probably March 2023. So, and most had it early on. So I would say it was the pre-Omicron problem and not so much maybe now.
Okay, thank you. Leslie Fellows, would you like to unmute yourself?
Sure. Thanks for inviting Nancy to give these rounds so I could catch up on the findings from this project. I just wanted to mention, because we were talking about just approaching the symptoms that, to try to help people feel better, which of course makes sense, but that the pharmacological profile is actually pretty interesting. I recommend looking at that paper. It sort of shows what we give when we're not sure what's wrong. And boy, do they ever have a lot of anticholinergic and other effects on the brain that are probably not helping cognition or fatigue. I don't know if Emily McDonald's in the audience, but this is ripe for potential intervention there to see how much we may be making people worse rather than better, either from medication we're giving or from the advice to stay in bed, which is, I think, pretty much in the history of medicine, never been good advice, not to contradict the WHO. I think in general, to keep in mind that although Nancy gave a great, way of making sense of the data to try to have some sort of causal type models, that we really do need interventions to see what the direction of causality really is in these various factors. And lots of things that were identified here have potential interventions. So that would be, to me at least, really interesting to pursue. Yeah, thanks, Nancy.
Well, thank you for not asking a question and answering them, because you know I'm not going to answer those questions, right? That's why we made such a wonderful team.
There you go. Ernesto, you have a question?
Yes, I do a long COVID clinic. And although this is anecdotal, my impression is that many of the patients that I see have a prior history of mental health conditions for which they were actually receiving medication. So it's objectively a diagnosed mental condition, generalized anxiety or depression. Some are bipolar and so on. And so my question is there any evidence, rigorous evidence that indeed prior mental conditions predict development of long COVID?
We only have our data. We asked that question. It did not seem to resonate that this group was ill before, but I have heard from other colleagues that COVID exacerbated other conditions like thyroid, certainly any of the anybody that had a respiratory problem. So it could exacerbate things. I did not see a signal in our data that these people had I mean, maybe there's one or two, but there wasn't a statistical on average effect that they had problems, major problems before. But maybe those people with major problems before chose not to enter our sample.
Thanks.
Thank you. Sasha Bernatsky, do you want to unmute?
So, as was just said, I think that there's this interesting possibility that mental health plays a role, and I in chronic fatigue, which I feel like this is chronic fatigue or fibromyalgia, like so. I guess in chronic fatigue and fibromyalgia, depression is a huge part, and again, it's hard to tease out, is it, you know, a cause or effect of their symptoms. But I did wonder if, you know, those first couple of years of COVID, it was terrible. What we lived through was terrible. It didn't even matter if you're a healthcare professional or not. Lots of people lost loved ones, and then family relationships deteriorated. And I just feel like my hypothesis for fibromyalgia is sometimes, like, because in fibromyalgia, if you have this like abusive relationships, that puts you at risk, it seems, for fibromyalgia. Some of the data suggests that. So I'm just wondering if we get some kind of effect modification where two people get COVID, but maybe one person gets long COVID because of some kind of effect modification by trauma, emotional trauma.
You heard that?
Yeah, I'm not sure I have any answers. I'm just always saying there's so many people with long COVID. They can't all have been ill before. You know, like there's some very ordinary people that were suffering from it. I don't know the chronic fatigue and the long COVID people have sort of got together and saying it's very similar. I don't know that much about fibromyalgia, except more joint pain and that itself is fatiguing, whether there's a primary effect of brain. So certainly in the multiple sclerosis world, fatigue is considered neuroinflammation. So versus myelin, which is fatigability. So I think there's connections to be made. And I think maybe that long COVID problem that we have might inform some of the other conditions, because there's just so many of them. I'm sure that wasn't an answer, but.
No.
Just that we have a comment, and then we'll take one last question. Leslie Fellows made a comment that many of those infected early were healthcare professionals, probably one of the reasons that PTSD profile was prominent. Stephen Grove.
I have to agree with Leslie that for many years we've had all kinds of conditions that we either put people to bed or kept them in the hospital for a few days, and all of that stuff has disappeared. Mobilizing them wherever possible has clearly been shown to be therapeutic. It's a terrible thing the World Health Organization has said. I don't for a moment doubt that getting out of bed and exercising is a challenge for these people, but there are ways to do it slowly and progressively and make sure that they don't beat themselves up because they didn't exercise today. And it's such a vicious circle, being sedentary and being tired. And arguably, in the absence of a clear-cut diagnosis or clear-cut pathophysiology, even if it's just a placebo effect, it's probably one of the most useful things we can do for these people. I'll bet you anything.
Like Tao, you're on. We have just 1 minute left. Do you want to make a comment? Because I know that Dr. Nguyen does take care of the cardiovascular symptoms of COVID patients. Tao, are you there? Go ahead.
Yeah, hi. Thank you, Nancy, for did a great job. I have personally followed about 300 patients like that now, and I have to say there's an overlap with chronic myalgia and myelitis and encephalitis for the CNS and the chronic fatigue syndrome. But the big difference is cardiovascular disease. They have a lot more pus and pericarditis, myocarditis, and also the mention of mental health disease prior to this. I don't think it's true. It's more of a reactive. Like there are a lot of people out there who were perfectly healthy before and get long COVID. So I think there is a bias of selection of patients who come to us who are so severely affected and get the disease. So, and this is a really sad, very sad case, much worse than the acute COVID. So thank you, Nancy, for a wonderful talk.
Thank you.
So we are coming up on the hour. Well, there's more comments coming in, which I'll let you read, Nancy. So thank you very much for this wonderful presentation, for all your work. Congratulations for all your work done, obviously, in advancing, advancing knowledge in this complicated area. And I agree, great methodology. I think that always to keep in mind that it's partly the content and the methodology that was used, which is obviously innovative in of itself. So thank you very much. Thanks everyone for joining us. I wish everyone a great afternoon.
Thank you.